in critically ill patients or patients with high level of D-dimer or fibrinogen level. Finally, participation in well-designed clinical trials and or epidemiological studies when they become available is recommended. COVID-19 patients who are managed as outpatients, generally anticoagulants or antiplatelet therapy should not be initiated for VT prophylaxis or at therapeutic doses in outpatients. Therapeutic anticoagulants empirically in patients with COVID-19. Should seriously ill COVID-19 patients receive therapeutic intensity anticoagulants empirically, that is the absence of confirmed or suspected VTE. Microvascular thrombosis is hypothesized to be involved in hypoxic respiratory failure in some patients with COVID-19. Autopsy studies to date have been limited, but they do show a large vessel and microvascular thrombosis, pulmonary hemorrhage, and high prevalence of VTE. Microvascular thrombosis may also be responsible for multi-organ failure in these patients. Although retrospective cohort studies of patients treated or non-treated with anticoagulants have been published, such observational data should not be used to support changes in practice due to the survivor bias, confounding by indication, and lack of adjustment for important patient comorbidities and other treatments. Whether critically ill patients should receive therapeutic intensity anticoagulation in the absence of confirmed or suspected VTE and other treatments. Multiple randomized controlled trials are investigating the effects of different doses of heparin or unfractionated heparin on patient outcomes. So participation in clinical trials rather than increased use of therapeutic dose heparin in COVID-19 patients with no other indication for therapeutic dose of anticoagulation is recommended. COVID-19 patients who experience recurrent clotting despite prophylactic anticoagulation. How should we manage COVID-19 patients who experience recurrent clotting of access devices, for example, central venous catheters, arterial lines, or patients undergoing, for example, CRRT, ECMO, despite prophylactic anticoagulation? What should we do? Although of unproven benefit, it may be reasonable to increase the intensity of anticoagulation, that is, from standard intensity prophylaxis to intermediate intensity prophylaxis, or from intermediate intensity prophylaxis to therapeutic intensity, or switch anticoagulants in these settings. Any decision to increase the intensity of anticoagulation should take into account the individualized patient's bleeding risk.
Dr. Beta, excuse me, can you open your camera just to start video? Sure, open your camera, please.
Of course.
Okay, I'll send you a request to open the camera.
Okay.
Okay. Thanks a lot.
You're welcome.
Please. Thank you.
And post-discharge thromboprophylaxis. Should COVID-19 patients receive post-discharge thromboprophylaxis? Patients hospitalized for acute medical illness are at increased risk for VTE for up to 90 days after discharge. This finding should apply to COVID-19 patients too, though data on incidence are not yet available. Therefore, it is reasonable to consider extended thromboprophylaxis after discharge using the approved regimen. For example, for rivaroxaban, 10 milligram daily for 31 to 39 days after discharge, or for example, betrixaban, 160 milligram on day 1 and followed by 80 milligram once daily for 35 to 42 days after discharge. Any decision to use post-discharge thromboprophylaxis should consider the individualized patient's risk factors of VTE, including reduced mobility, bleeding risk, and visibility. from-hospital approaches for COVID-19 patients involving early discharge have been suggested to free up inpatient beds. So a status at discharge should be considered in any decision to use VTE prophylaxis in these unique patients. As you know, aspirin has been studied for VTE prophylaxis in low-risk patients after orthopedic surgery and could be considered for COVID-19 patients VTE prophylaxis if criteria for post-discharge from prophylaxis are met. And also, patients should be educated on the signs and symptoms of VTE at hospital discharge. And a special consideration for therapeutic anticoagulation. If a patient with COVID-19 requires therapeutic anticoagulation for VTE or, for example, for AF, for example, for stroke prevention, are there any special considerations? The answer is yes. Using low molecular weight heparin or heparin in hospitalized critically ill patients is recommended because the shorter half-life of these medications, ability to be administered intravenously or subcutaneously, and fewer drug-drug interactions in comparison with direct oral anticoagulants. Regular warfarin users who are unable to get INR monitoring during isolation may be continued or candidates for direct oral anticoagulant therapy. Patients with mechanical heart valve, ventricular assist devices, valvular atrial fibrillation, and antiphospholipid antibody syndrome, pregnancy, and lactation should generally continue treatment with warfarin therapy. And what is the special consideration during pregnancy and lactation? Management of anticoagulation therapy during labor and delivery requires specialized care and planning and should be managed similar in pregnant patients with COVID-19 as other conditions that require anticoagulation in pregnancy. Unfractionated heparin, low molecular weight heparin, and warfarin do not accumulate in breast milk and do not induce an anticoagulant effect in the newborn. So they can be used in breastfeeding women with or without COVID-19 who require VTE prophylaxis or treatment. In contrast, direct-acting anticoagulants are not routinely recommended to the lack of safety data in breastfeeding or pregnancy situations. Considering drug interactions is very important, at least as a pharmacist. You know, multiple medications are under investigation for COVID-19, so the risk of drug-drug interactions may be high. For example, tocilizumab or sarilumab can increase cytochrome P4 and 150 enzyme activity. So apixaban and rivaroxaban should not be used with tocilizumab or sarilumab, and for warfarin, the increasing dose may be required. Another example, antiviral medications like atazanavir or lopinavir-ritonavir will increase drug concentrations of apixaban or rivaroxaban, and also decrease the active metabolite of clopidogrel and prasugrel. So again, considering drug interactions is very important in patients with COVID-19. And patients with chronic use of anticoagulants before COVID-19. Patients who are receiving anticoagulant or antiplatelet, for example, aspirin, Plavix, warfarin, heparin, enoxaparin, or rivaroxaban therapies for underlying conditions should continue these medications if they receive a diagnosis of COVID-19. And at the end, in summary, you see a table of another approach to monitoring and anticoagulation use in patients with COVID-19. It should be noted that all patients hospitalized with confirmed or suspected COVID-19 should have coagulation tests, including PT, PTT, INR, D-dimer, fibrinogen, and platelet count. As you see, in ICU patients and also patients with ARDS, acute respiratory distress syndrome, patients in ICU, and patients with ARDS. The escalate dose or intermediate dose of heparin or low molecular weight heparin may be beneficial. As I mentioned, for example, heparin or enoxaparin as intermediate or escalated doses. In patients with confirmed VTE or high prevalence for PE or pulmonary embolism, we should start anticoagulants in therapeutic doses. Thanks for your listening. It was a pleasure being here today. Does anyone have any question or comments? I am happy to answer your questions at the discussion panel. Thank you.
Thank you very much, Dr. Bita. Thanks for this nice and valuable presentation. Really, you give us a lot of information and you cover the topic totally from regarding all the points that related to it. Now, I think we have to cover the second topic of our symposium today. By our next speaker is Professor Dr. Mohammed Dakhil Al-Rikabi. He is the Dean College Pharmacy of Al-Kafil in Najaf. Dr. Mohammed, it's your time. You can start your presentation. Thank you.
Okay, thank you, Dr. Qutaiba. Thank you all our audience. First of all, I would like to introduce myself to those who don't know me. I'm Dr. Mohammed, Professor of Clinical Pharmacy, the Dean of College of Pharmacy, University of Al-Kafil in Najaf, as you know. I would like, of course, to thank the University of Basra College of Pharmacy for this invitation for this very important webinar. And of course, thank you for you, Dr. Qutaiba, the organizer of this webinar, for this very nice administration of the webinar. Today we're going to be talking about the use of antiviral medications in the treatment of COVID-19. And specifically, we will talk about remdesivir and favipiravir and try to cover or to display the articles that talk about the approval or their pre-approval state of remdesivir and favipiravir. You know, we have introduce something to give the audience something about the coronavirus. As you know, is a family of viruses called beta viruses. Common people mainly and even many different animals may be affected, like cattle, like bats may be affected and may be infected with this virus. The virus, of course, affects the upper respiratory tract, and the signs, as you know, of COVID-19 is recently became well known for all, even for ordinary people. For the matter of the limited time, I will go directly to talk about the use of antiviral medications in the treatment of COVID-19. And as you know, the antiviral medications or the use of antiviral medication to treat viral infection is a common procedure in the clinical practice. So there's a paper, you know, that published in the Journal of Internal Medicine talk about the use of antiviral and the importance of using antiviral in the treatment of COVID-19, and its recommendation that early use of antiviral in the treatment of COVID-19 may contribute to alleviate the symptoms, especially in elderly patients. And we will only emphasize on two types of antiviral which are recently went viral in the medical practice. They are remdesivir and favipiravir. As you know, remdesivir you know, it's a broad spectrum antiviral agent, first synthesized and developed by Gilead Sciences, pharmaceutical company, you know, for the treatment of Ebola virus. It's the main activity of remdesivir is related to its metabolite, which has no name. We are only just like a symbol. So its activity is mainly by the inhibition of RNA-dependent RNA polymerase in the virus to stop the viral replication inside the pneumocyte or inside the human body in general. If we look for the history of remdesivir, remdesivir developed in 2009 to try to treat hepatitis, but unfortunately it didn't show an effectiveness in the treatment of hepatitis C. In 2015, the remdesivir or US Army Medical Research of Infectious Disease has used remdesivir and stated that it blocked Ebola in rhesus monkeys. And 2018 was used in March, a few months later, in March 2018, a study published showed potential susceptibility of SARS and MERS in vitro, as well as SARS in vivo using mice. In February 2020, I mean, showed a positive result. It seems that it showed a positive result against SARS-CoV-2. And in March 2020, another study showed that remdesivir has antiviral activity against SARS and MERS in vitro, MERS in vivo with mice, and SARS and MERS in vivo with rhesus monkeys. It became very clear for the specialists and even for those people who are studying such type of medications that the mechanism is, again, is the inhibition of RNA-dependent RNA polymerase. So stop the viral replication, no viral replication, decreasing viral load, and hence it could be a potential treatment for COVID-19 or other viral infection. Actually, many papers and articles have been published regarding the use of or the potential activity of remdesivir for the treatment of COVID-19. But I will only focus on the most important. We have 4 studies that may rationalize the use of remdesivir in the treatment of COVID-19. The first study done in Wuhan, you know, the Wuhan is the origin of the virus. So the first study conducted in Wuhan, China, from February 6 to March 12. It was a randomized controlled trial with a small sample. The sample size was 237 participants. Unfortunately, there was no statistically identified benefit from this study, but they perhaps noted a faster time of recovery. Although it is not that much statistically significant, but there was a good, like, promising if we extend the study. There was also a minor but not statistically significant increase in mortality in a group of remdesivir. I mean, remdesivir increased the mortality in the group of remdesivir versus or compared with the control group, which was 14%. So they recommend further investigation with larger clinical trial, and hence another trial done by Gilead. Gilead, you know, the company that produce remdesivir. Gilead put safety, efficacy, and dosing trials. We have actually 2 trials of Gilead. The first trial, called Simple One, studied the efficacy and safety of 5 days versus 10 days treatment of remdesivir The drawback of this study that it had no control group, which is considered as a con for this study. So the study is initially planned for only 400 participants, then expanded to 6,000 participants in many countries. And they did this trial specifically looking for severe manifestation of the disease. So on April 29, they have published, which showed that 5 versus 10 days really have same clinical improvement of the disease. I mean, there is no significant difference between the period of 5 days compared with 10 days. And they noticed that those who given the treatment within 10 days of the symptoms onset did have an improved outcomes when compared with those given treatment after 10 days. And this is a very important finding of the Simple 1 trial. The other trial of Gilead include the also, again, they studied the efficacy and safety of 5 days versus 10 days of treatment. It did have a control group, which is good point for this trial. It was initially planned for 600 participants, but again, expanded to 1,000 participants. And they did the trial specifically looking for something else, looking for moderate manifestation of the disease, while Simple 1 trial was looking for severe manifestation of the disease. This trial is still ongoing. We are waiting for their results soon, maybe in this month. And it seems to be promising because, you know, the design of the study is more advanced than Simple 1. The third trial that again may rationalize the use of remdesivir is the WHO Solidarity trial, multi-center trial, and they try to find an effective treatment for COVID-19. The objective of this trial, they enroll patients all around the world. It does have a control group of standard care, which is a good point for this trial. They used many options, including remdesivir, chloroquine, hydroxychloroquine, lopinavir, ritonavir plus interferon alpha, you know, the rationale of interferon alpha. And this trial is a pretty big, extensive trial. It is still ongoing trial. And actually, I'm very enthusiastic for the result of this trial because it's very big trial and well designed. So we hope that the result will come soon. And the final trial is the trial of the National Institute of Allergy and Infectious Disease, which is a part of National Institute of Health. This trial primarily looking for an outcome of time. As some of you know, this course, 10 days course, is identified in FDA emergency use authorization. This is a randomized control trial, double-blind, placebo-controlled, multi-center, which is a gold standard for the trial that we want to see. This is very well-designed trial. They looked for hospitalized patient with an illness of any duration. It's not like put a condition that the duration of the illness should be early or should be in the late stages, any duration, which is a drawback for the trial. It enrolled about 1,063 participants, and it is ended early because it showed statistically significant shortening of the duration of the disease. And it didn't show a statistically significant reduction in mortality. Based on this trial, the National Institute of Health put many recommendations for using of remdesivir in the clinical practice, as you know. So they recommend the use of remdesivir for the treatment of severe COVID-19 hospitalized patient whose oxygen saturation may be lower than 94%, or those require oxygen therapy or require maybe ventilation or ECMO. Also the severe and hospitalized patients who are not even intubated. And the panel states that the data are insufficient regarding optimal duration of remdesivir in patients with mechanical ventilation or ECMO, or for those without adequate improvement of maybe 5 or 10 days remdesivir regimen. And finally, the NIH panel state that the data are insufficient to recommend or against the use. They are like neutral in the recommendation or using remdesivir for the treatment of mild to moderate, and they recommend remdesivir for the treatment only severe cases of remdesivir. Based on the recent study and based on the recommendation of NIH, the Iraqi Ministry of Health put a recommendation or like protocol for the treatment of COVID-19 in Iraq, which is approved recently and published at the as official document from the Ministry of Health, Iraqi Ministry of Health. So they recommend the use of remdesivir for severe cases, and they define severe cases as those who meet the following criteria: respiratory distress syndrome with respiratory rate more than 30 minutes, or respiratory rate more than 40 minutes in children less than 6 years, or those patients with a blood oxygen saturation less than 93 on ambient air, or those whose the ratio of PA oxygen on FI oxygen less than 300, or those who have lung infiltrate more than 50%. So they recommend remdesivir in a certain disease, in a certain regimen, and only for the states of severe conditions. Regarding favipiravir, I will only summarize because the limited time, summarize the paper or summarize the rationale for its approval. I will just remind you that favipiravir is antiviral drug that selectively inhibits RNA and DNA. Dependent RNA polymerase act by the same mechanism like remdesivir, and this make it effective against many viruses and make it promising for the treatment of many viral infections like COVID-19. One of the important articles that published regarding the use of favipiravir is this is article that published in Engineering, which is like experimental treatment of favipiravir for COVID-19. It was only open label control study. More than 320 patients participate in this study. They compare favipiravir with the standard anti-HIV therapy, and they found that the patient taking favipiravir recovered within 10 days compared to the 12 days in the other group. And this is very attractive result. In this pilot study, it was non-randomized, which is a drawback again. They found that favipiravir showed significant and better improvement of patients with COVID-19 regarding the disease progression and viral clearance. So in India also, Glenmark, it's a biopharmaceutical company, has initiated a phase 3 clinical trial on favipiravir. And this trial being conducted in 10 different hospitals in India. Around 150 patients participated in this trial. They all were mild to moderate cases. It compared favipiravir against standard therapy using the duration of therapy of 14 days, and the duration of the whole study was 28 days. And the study will be completed on August. And in Japan also, Fujifilm Toyama Chemical Quality already announced that it started a phase 3 clinical trial on favipiravir, and they waiting for its result. And Russia also declared that the result of a clinical trial on avifavir, which is a generic name of favipiravir, they found that the symptoms of COVID-19 and specifically fever disappeared after 3 days, only 3 days, compared with 6 days using the standard therapy, and it reduced the duration of the disease by half. So the Ministry of Health at Russia approved avifavir, which is again favipiravir, for treatment of COVID-19, and they announced that it cuts the duration of the illness by 50%. And the protocol in Iraq is also dependent on the well-published and designed studies. So they included the favipiravir in the treatment of mild and to severe cases in the Iraqi protocol. So favipiravir is used in a dose of 1,600 milligram per dose, twice daily on the first day, then 600 milligram twice daily for 7 days for moderate cases and also for severe cases. Actually, my opinion about the approval of remdesivir of favipiravir, although we have not yet complete clinical trial that give us a solid evidence that they are effective for the treatment of viral infection, but the world has no choices. They have to approve something for the treatment of this infection. So they jump the gun and early approve those medications for the treatment of this pandemic. We hope that the result of the clinical trial will come soon and published and approved and depended by the clinical community, because we are all waiting for a radical solution for this pandemic to return to our life. And thank you for all. Thank you for the University of Basra and Dr. Qutaiba, and sorry for being long. Thank you.
Thank you very much, Professor Mohammed Al-Rikabi, for this informative, really, and valuable informations. Really, you cover all updated informations about these medications, antiviral medications, remdesivir and favipiravir, and their approval, about the large clinical trials. Thank you again for you and for joining us today. I think we have to go to our final topic today, which is the use of corticosteroids in fighting the COVID-19 and fighting the coronavirus in a critically ill patient. And our final topic presented by Assistant Professor Dr. Ali Muhammad Hadi, in College of, which is working in College of Pharmacy, University of Basra. Now it's the time for you, Dr. Ali. You can start. Thank you.
Yes. Thank you very much. Do you hear me?
I hear you, yeah, clear.
Yeah.
Thank you.
Okay, thank you very much for Dr. Qutaiba for introducing me. I am Assistant Professor Dr. Ali Muhammad Al-Ahmad, faculty member in the College of Pharmacy, University of Basra. I am a PhD specialist in clinical pharmacy, 2012, and also postdoctoral fellowship in critical care pharmacotherapy, Tehran University of Medical Sciences, 2020, and yet. I would like, it's a good, a nice time to welcome all the audience, and it's a good morning for us to meet in this activity. I would like to welcome all of the audience and all of the visitors and especially the international presenter, Dr. Shahrami from Tehran University of Medical Sciences, and the Professor Muhammad Al-Rikabi from Al-Kafil University. So just to start my short notes really about the updates on the use of corticosteroids in fighting COVID-19. Is it harmful or life-saving? This is a controversial subject. And still now, there are no complete picture about using steroids and coronavirus invasion, worldwide. So we have to focus on these short topics and short slides on the significance of the use of this drugs in critically ill patients. At first, we should go to screen the coronavirus itself as a virus. Historically, coronavirus SARI is one of the coronaviruses that discovered lately in 2000s or 2001 in China, and the sequence of coronavirus infections, especially the SARS-CoV-1 and MERS. And this virus finally have mutations, and it appears just like this molecule, the most pathogenic and virulent features of this virus is the spike proteins, and this is envelope protein. And it needs, especially in the host cells, invaded host cells, it needs the receptor AC2. So let us go to focus on the immune dysregulation of host cells or host body. Most of severe COVID-19 infections have persistent very high level of ESR, C-reactive protein, and high level of cytokine, pro-inflammatory and inflammatory cytokines. So this can lead finally to the progression of the disease in severe cases into the appearance of ARDS, hypercoagulation, disseminated intravascular coagulation, and it is very possible that cytokine storm exacerbates lung damage as well as lead to other fatal complications. It was recognized that COVID-19 illness exhibited 3 grades. So you should know and should focus on the 3 grades of COVID-19 infection. It's about 80 to 90% of patients with a mild condition. And this is in the grade 1 of infection. Some patients can go to the grade 2 or even grade 3, which is the moderate to severe grades of infection. So it's about 80% to 90% of patients worldwide are stay in the grade 1, which is the mildest grade of infection, where the immune system can overcome the virus and eliminate it. So a small proportion of COVID-19 patients would transit into the third and most severe stage of illness, which manifests as an extrapulmonary systemic hyperinflammation syndrome. In this stage, markers of systemic inflammation initiates anti-inflammatory therapy is critical. How to block? So it is how to block the cytokine storm. This is the question that we should ask, and this is the answer that we should focus on: how to block the cytokine storm, and where's the significance of immune modulatory or anti-inflammatory drugs all in all. So we should focus on the cytokine storm in the small proportion of severely ill patients or critically ill patients, and the use of corticosteroids is critical for reducing death rate of COVID-19. The immune system was impaired in clinical ill COVID-19 patients. Lymphocytopenia is one of the most prominent markers of COVID-19. It's also one of the criteria for COVID-19 infection. Both T cells and natural killer cells in patients with COVID-19 were reduced. The degree of reduction was even lower in severe cases. The latter had higher leukocytes count and the neutrophil lymphocyte ratio as well. In some critically ill patients, Natural killer cells were extremely low or even undetectable. In addition, memory T helper cells and regulatory T cells were obviously decreased in severe cases. So this is the problem. This is the problem. The problem is that the immune system of the host, unfortunately, in a small proportion of patients is defective and dysregulated, where the lymph nodes, spleen are shrinked and decreased in size and decreasing the progression and the release of inflammatory cells or immune cells. Most strikingly, the autopsy finding revealed that the secondary lymphoid tissues had been destroyed in COVID-19 patients, which is very unusual from other cytokine storm-related diseases. So the problem here in the immunity, and this is the point that should be focused on really, where when we are using corticosteroids, we will decrease further immunity. And this is the controversy, and this is the point of debate, why we use corticosteroids and why we don't use corticosteroids. We use corticosteroids to fight cytokine storm. However, in these patients infected with COVID-19 or COVID-19 patients, unfortunately, the immune system is distracted, has been destroyed. So the use of corticosteroids should be carefully and cautiously, as I will focus on in coming slides. Also, spleen atrophy, as we said, lymph node atrophy, immunohistochemical staining showed that CD4 T cells and CD8 T cells were decreased in spleen and lymph nodes. In addition to that, in patients with diffuse alveolar damage, the major inflated cells were in monocytes, macrophages, moderate multinucleated giant cells, but very few lymphocytes. So the problem here mainly in the lymphocytes. There are two possible reasons for destruction of immune system in patients with COVID-19. So why the immune system is defective, why the immune system is dysregulated in patients with COVID-19, this is due to two possibilities. Either the lymphocytes directly invaded by the virus or indirectly damaged by the cytokine storm. The answer is the lymphocytes indirectly affected by the cytokine storm. Why? Because you know, COVID-19 or SARS-CoV-2 wants to find AC2 receptors on the cells. And you know that T cells, T lymphocytes, absent or have no these receptors. So they are destroyed, unfortunately, by the cytokine storm. And this explains the immune disturbance in the patients infected with COVID-19, where the virus can trigger the cytokine storm, and then the cytokine storm go to the immune cells to kill them, and especially those cells which are potent in fighting the virus. So the virus is very clever. He goes to the enemy, direct to the enemy, which is the T cells, and disable these T cells. Another prominent clinical manifestation, you know, in severe COVID-19 patients is endothelial damage. And this is a problem really, and this is a story. Also, we find that mimicry of vasculitis could be seen in severe COVID-19 patients. So vasculitis, you know, it is a condition of inflammation of endothelium and all blood vessels and all over the body. And this is the condition that is uniquely managed by steroids. And this is the significance of steroids also in COVID-19 patients, is to fight vasculitis-like disease. Clinically, many clinically ill patients have vasculitis-like manifestations, you know. Pathology examination revealed that the blood vessels of alveolar septum were congested and edematous. And this is called acute lung injury, when the blood alveolar septum and alveoli of the lung are filled due to a series of pathological consequences, lead to infiltration of the alveoli and decrease the oxygenation. And this is the problem due to hypoperfusion of bloodstream or blood circulation into the alveolus. And the alveolus will be edematous, and this is called non-cardiogenic pulmonary edema, with the modest infiltration of monocytes, lymphocytes within the round blood vessels. And this is called acute lung injury or acute respiratory distress syndrome. Here we can see how the virus can invade the host cell and how the host cell then finally recruit these immune cells, monocytes, macrophages, T cells. These cells are recruited, and these cells can secrete and release pro-inflammatory and inflammatory cytokines like interleukins, like tumor necrosis factor, and interferon gamma, and etc. So here we are in two roads, either to go to the green road or to go to the red road. Those patients, the majority of patients infected with COVID-19, 90% about of them, with healthy immune response. You see, please look for me carefully, listen to me carefully. Here, the patients with healthy immune response. These patients can eliminate the infecting organism and neutralize it, and then it will be expelled. Unfortunately, some percent of patients, which is about 10% to 15% of patients, that undergo severe illness. Those patients with dysfunctional immune response, where excessive infiltration of monocytes, macrophages, systemic pulmonary edema and pneumonia, and this is the problem also. Widespread inflammation and multi-organ damage. So we have 2 points. We have and edema and acute respiratory syndrome. So also small vessels showed hyperplasia, hairline thrombi, of micro vessels also found. So also one of the pathology involved in the development of alveolar edema, all of them can contribute to the appearance of high inflammation and severe illness. Inflammation in COVID-19 patients, no doubt, antiviral and supportive treatments are very important in the treatment of patients with COVID-19. And as I said, it is the majority of patients. As cytokine storm is relatively common in severe cases and often leads to the exacerbation, anti-inflammation therapy may help in preventing further injury. As you know, including non-steroidal anti-inflammatory drugs, glucocorticoids, chloroquine, hydroxychloroquine, immunosuppressants, inflammatory cytokines antagonists like interleukin receptor 6, monoclonal antibodies, TNF-alpha inhibitors, interleukin-1 antagonists, Janus kinase inhibitors, and etc. All of them are anti-inflammatory. However, the focus of us here in the use of corticosteroids was suggested that tailored therapy in stage 3, as I said, hangs on the use of immunomodulatory agents. So the use of corticosteroids may be justified. So I would like to refer here the timing, the proper timing of insertion corticosteroids in the management of COVID-19 is very important, and it should be very cautious. The patient should be very cautious in using corticosteroids, clinicians should be very cautious in using corticosteroids for patients with critical illness. Why? As I will talk about in the next slide. So the immunomodulatory like tocilizumab, IVIG, also modulate immunity and are very well working in critical illness and severely critical. Overall, the prognosis and recovery from all this critical stage and illness is poor. So the initiation of these anti-inflammatory drugs is very, very critical. Here I would like to ask some questions and answer about them. Should we apply anti-inflammatory therapy to all COVID-19 patients? The answer is no. Which patients should we treat with anti-inflammatory regimen and when to start? As I will answer this in the preceding or in the coming slide. What is the treatment duration? Which medication is best choice? All the above questions are still under intense debate and do not reach a consensus. So it is worked by country, you know. The guidelines and the protocols differ from country to country. The main concern is that the anti-inflammatory medications like corticosteroids may delay the elimination of virus and increase the risk of secondary infection. So this is why we know to prefer using corticosteroids in ICU, because it eliminates the virus clearance and it leads to secondary infections, and it leads to also psychosis and other consequences. So the time window of anti-inflammatory corticosteroid use is very important. According to reports and observations, severe infected patients usually underwent abrupt deterioration in 1 to 2 weeks after onset, and the prompt initiation of the anti-inflammatory therapy at this extremely short period window is likely to achieve a favorable treatment response. So it should be evaluated. Patients should be day by day, hour by hour, should be evaluated for the need to use corticosteroids. It should not be inserted as a blind point in our protocol. So it is a clinician idea. It is a clinician decision. It is a clinician case-by-case decision. So some cases can need corticosteroids. Who are these patients that need corticosteroids? We'll see. Numerous clinical studies have reported the efficacy of glucocorticoids in SARS and MERS previously. You know, since 2003, glucocorticoids were used. However, some clinical trials enhance the use of glucocorticoids. Some of the clinical trials reject the use of glucocorticoids. So timely usage of glucocorticoids could improve the early fever, promote the absorption of pneumonia, and obtain better oxygenation. However, some studies also see that corticosteroids, as I said, that they delay virus clearance, leading to the deterioration of the disease. So at the present, systemic glucocorticoid administration was empirically used for severe complications in order to suppress cytokine storm manifestation patients with COVID-19, such as patients with ARDS, acute heart injuries, acute kidney complications. So these narrow and small number of patients can utilize the use of glucocorticoids in very critical point of their management. As I said, that these patients which are very critical ill and where they have ARDS, oxygen saturation less than 90%, and lung edema and infiltration is present. So a lot of clinical trials, some of them enhance the use of glucocorticoids, and some of them reject the use of them. So steroids may be indicated. This is the vast majority of scientists and critical in ICU enhance the use. In ICU don't use corticosteroids too much, and it is not your routine drug in ICU. As we said, it is immunomodulatory, and for patients with cytokine storm, when the cytokine storm is evident, and there is evaluation for patients with a cytokine storm, and those patients with vasopressor refractory shock, asthma COVID exacerbations, and for antenatal therapy at risk for preterm birth. Also, these can utilize from using glucocorticoids, as well acute lung injury, respiratory distress syndrome. All of them can utilize the use of corticosteroids. However, also corticosteroids are proposed to be benefit in suppression of lung inflammation. However, unfortunately, some studies find that glucocorticoids, a prolonged mechanical ventilation stay and prolonged ICU stay may lead to vascular necrosis, delay viral clearance, and secondary infections. So, so here I want to focus on, we need corticosteroids in cases of septic shock, bronchoconstriction, and clinical trials are ongoing to approve the use of these glucocorticoids. One important point I want to focus on is the WHO recommendation. WHO recommended that corticosteroids should not be used in the treatment of viral pneumonia or ARDS. So it is country by country. It is case by case. There is no recommendation for blind use of corticosteroids all over the world. And if used, glucocorticoids, if used, must be used with comments with caution. And the prudent dosage should be promoted under certain circumstances. Here we can focus on the clinical trials that are happening in the world. Juan Lee and Ital said or stated that the glucocorticoids or corticosteroids used in subjects with SARS-CoV-2, SARS-CoV-1 MERS infection delayed viral clearance and did not convincingly improve survival. And also Alazani W stated that the new consensus guidelines recommend considering methylprednisolone for only intubated patients with ARDS. So only intubated patients. And you know that there are criteria for intubation. Not every patient with ARDS needs intubation. Some of them can use face mask or cannula oxygen. For those for intubated or intubation, we can use steroids. Steroids also may be indicated for vasopressor, refractory shock, as I said, asthma, cough, exacerbations, and etc. Very recently, you know, in one preliminary report, Dr. Peter Hobby and Dr. Martin G. Landry from UK recovery trial stated that in patients hospitalized with COVID-19, dexamethasone 6 mg for 10 days reduced 28-day mortality among those receiving invasive mechanical ventilation or oxygen at randomization, but not among patients not receiving respiratory support. So dexamethasone can be used, and it's just a preliminary report. Based on these results, one death would be prevented by the treatment of around 8 patients. So the available is not strong enough to support the use of corticosteroid therapy for the treatment of myocarditis associated with COVID-19, as the benefits are uncertain, coupled with possible delayed viral clearance and risk of secondary infections. So also some clinical trial said that myocarditis associated COVID-19 is not worthy to give corticosteroids for these. So the lack of survival benefit has been further supported, and the increased risk of psychosis, avascular necrosis, prolonged viremia, and hyperglycemia, all of them can limit the use of corticosteroids in ICU. Corticosteroids should only be considered if required for an alternative indication like septic shock and bronchoconstriction. Finally, we should focus on the timing of use of corticosteroids in ICU, and the usual dosage and the usual duration, and which are the type of patients. We said that patients with septic shock, patients with hyperinflammatory lung disease like COPD, asthma, and bronchoconstriction, patients with intubated in ICU may require, in case of cytokine storm, they may require the use of glucocorticoids. Others do not use glucocorticoids, so it should be used timely and should be used consciously. Thank you for listening, and I am sorry for prolonging. Thank you all.
Thank you, Dr. Ali, for presentation. Thank you for covering the topic about the use of corticosteroids. Really, you give us a lot of information about the subject, about the contraindications of the usage of corticosteroids, and how it should be used with caution by the clinicians for the critically ill patient. It is not about any patient can use the corticosteroids or indicated for anyone. No, it is it needed some limitations and with cautions for the clinicians. Thank you very much. I think we finish talking about all topics of our symposium today. Now I will open the Q&A session for attendees. Any one of the our attendees, anyone, if you have a question, just raise hand, and I'll permit unmute your mic just on talking. Ask your question, please, if you have a question. So, Dr. Haider, you can speak, you can unmute and speak. Dr. Haider? Okay. Dr. Uday? Dr. Uday Sajjad? I ask you to unmute your mic, Dr. Uday Sajjad, if you hear me. Now the Q&A session. Yes. دكتور عدي تسمعني؟ دكتور عدي؟ Our speakers now, you can open your cameras, please. Dr. Bita and Dr. Mohammed and Dr. Ali.
Okay, yes.
Thank you very much. And I'm waiting the attendees to ask the questions. I think Dr. Uday don't have any question. So let's go to Dr. Haider. Just unmute your mic, please, Dr. Haider, and you can ask your question. تسمعني دكتور حيدر؟ مجرد بس تفتح المايك حضرتك تتحدث. الحضور الكرام اللي عنده سؤال بس يرفع ايده يريز هاند ونفتح له المايك ويطرح سؤاله. إذا عنده سؤال مداخلة أعتقد الموضوع. نعم دكتور تفضل.
عندك اكو بالكيو اند اي مكتوب سؤال كتابه يمكن.
اي دكتور تفضل دكتور حضرتك. نعم عندنا. نعم السؤال هو هذا الأول. Where are the references for Dr. Bita recommendations? Dr. Bita, the question for you is your recommendations for using, I think, of the anticoagulant references. I mean, what you mean by references? You mean by the sources or the trials or studies or sources? Yeah.
Okay. As you know, data is very limited in COVID-19 and the further studies are required. I used many references, including NIH guideline and some articles in Blood Journal about the anticoagulations in COVID-19.
Thank you very much. Of course,
yes.
Of course,
show the reference.
Yeah. You can share your presentation. Yeah.
Yes.
Thank you. Take your time. Our attendees, if you have any question, just raise hand, please, and ask your question. I will unmute your mic to allow you to speak. After finishing the answer of the first question about the anticoagulants, the recommendations. So this is, I see the presentations. You can't see the references now on the screen, the references for the Dr. Bita about the use of the anticoagulants for the treatment or the COVID-19 patient. Now.
Sorry, Dr. Qutaiba, there is a question in the Q&A. What about using inhaled corticosteroids for COVID-19 patients?
Yes, Dr. Ali, you can answer, please.
Yeah, really, it's a very good question. However, as I said, that the use of corticosteroids is limited to the systemic cytokine storm. And you know, the cytokine storm is limited for the systemic cytokine storm. And there is no worth and no value for using corticosteroids inhalation there, because the inflammation is not limited to the lung. It's a systemic inflammation. And even the inflammatory changes and pathological changes, inflammatory pathological changes in the lung are attributed to the systemic involvement, because the thrombosis, because of, as I said, the pro-inflammatory cytokines and the immune cells, macrophages, cytotoxic T cells, all of them distract alveolar walls and distract the endothelium of the intra-alveolar septum and leads to the pulmonary edema and the progression of the disease. So I think that there is no value from using the inhaled corticosteroids for these patients.
So what's your opinion, Dr. Muhammad, about the talk of Dr. Ali? What do you think about
of course,
about the inhaled corticosteroids?
Of course, I think when we talk about the corticosteroid in general, the same recommendation is given for all corticosteroid. However, the injectable corticosteroid may be taken in like critical considerations, because the dose of corticosteroid, like injectable corticosteroid, is very high, and the situation of the patient, is a severe condition. While inhaled corticosteroid, I think the same limitation will go for the use of inhaled corticosteroid, as Dr. Ali said. But I have many. Can I answer the questions regarding my talk, Dr. Qutaiba?
Of course, Dr. Muhammad, you can.
Because they sent me a question here in the chat bar. They asking me about what do you think the best one of all these protocols, or I mean the clinical trials that I just displayed in my talk. Actually, the design of clinical trial, there should be a certain conditions for the well-designed clinical trial. It should be randomized. It should be like a placebo, well-randomized, placebo-controlled, double-blind, and the number of patients also is very critical. And also the duration of the clinical trial, is all these factors should be taken in consideration. So for me, I think the WHO trial and the NIH trial are both well-designed and fulfill the criteria of well-designed clinical trial. But unfortunately, the NIH trial had ended early because they find that there is significant reduction in the duration of the disease. And the drawback on the NIH trial is that they enrolled the patient of any duration. It's good to have enroll patient in early stages of the disease, just after diagnosis, to see whether or not we can stop the progression of the disease by this modality. But the WHO trial is still ongoing, and we are waiting for the result. Maybe the another question regarding the using of ACE inhibitors, or using antagonizing ACE2 receptor in the lung, and whether it is effective or not in the mitigation of infection or reducing the entry of the virus to the pneumocyte. Actually, the studies or articles published talking about this subject not yet put a cut off that there should be a recommendation to either stop or encourage the use of ACE inhibitors or angiotensin receptor blockers in this condition. However, the American College of Cardiology and the post of American College of Cardiology has stated that patients on ACE inhibitors or angiotensin receptor blockers should continue the use of these medications while he suffered from COVID-19. Yes.
Thank you very much, Dr. Muhammad. I think we have some questions from the attendees. Let's see. أبو محمد حضرتك ممكن تفتح المايك بس. I ask you for unmute the mic, your mic, and you can talk.
About using antiplatelet, can I answer?
Yes, of course. Dr.
Yes.
Rita, please, you can answer.
Yeah.
Thank you.
As I mentioned, aspirin has been studied for VT prophylaxis in low-risk patients after orthopedic surgery. And it could be considered for COVID-19 patients as prophylaxis for VTE if criteria of post-discharge from prophylaxis are met. So just after post-discharge for low-risk patients, aspirin can be considered. And in patients who are receiving antiplatelets or aspirin for underlying conditions before COVID-19, it should continue and if they receive a diagnosis of COVID-19.
Thank you very much, Dr. Bita. Now, I think we have العفو إذا تسمعني أبو محمد مكتوب ما أعرف الاسم تماما بس المايك مفتوح لحضرتك. حضرتك رافع ايدك إذا عندك سؤال ممكن تسأل. الحضور الكرام أي أحد عنده مداخلة حتى لو ما عندنا مشكلة بالعربي بالإنجليزي ما عندنا مشكلة. يعني المهم نسمع من عندكم لأنه ضروري جدا نسمع مداخلاتكم. نريد نعطيكم الوقت الكافي. احنا ما نريد بس السبيكرز أو المحاضرين فقط هم اللي يتحدثون. أتمنى أنه تكون مداخلات من قبل الحضور الكرام وشاكر جدا حضوركم وتواجدكم ويانا. واعتقد المواضيع مهمه جدا اللي جاي نطرحها لانه متداوله هذه الايام كثيرا متداول الحديث عنها فان شاء الله نتمنى انه نكون قدمنا المعلومات المطلوبه. So we have maybe another questions in a Q&A session. I think Dr. Muhammad you answer this. I can't. Okay. Thank you.
answer.
السلام عليكم.
عليكم السلام.
عليكم السلام ورحمة الله.
شكرا دكتور قتيبة. معكم دكتور حسن مجتبى المظفر بورد سيرتيفايد فارماكوثيرابي سبيشالست. سؤالي إلى دكتور علي أستاذي العزيز. دير حياكم الله دكتور. Dear doctor, I heard that you are going against the use of steroids in most patients with COVID-19. I think I heard that. But what are your comments about the recovery Oxford trial, which showed the benefit of 6 milligram dexamethasone, as you mentioned, in all patients with SpO2 less than 94 or needing oxygen therapy? They clearly not every one of them showing cytokine storm to start steroids with. What are your comments about this trial? They didn't show features of cytokine storm to start steroids. They generalize the use of steroids, and yet they show great benefit in 20%, I think, reduction in mortality in such cases. Thank you very much.
Yes, thank you, Dr. Al-Hassan. It is a great honor for us to answer your question. Really, I said that I'm not standing against the use of glucocorticoids in all the patients. I said that timely using and there are provisions. There are the patients should have cytokine storm and should have complications of the disease. And especially if you ask us about ICU management use of glucocorticoids, it is usual in case of refractory sepsis and septic shock, and in cases of also bronchoconstriction, and in patients with bronchoconstriction like those of asthma and COVID exacerbations. Also, you asked about the recovery trial of using dexamethasone. It is still a clinical trial, it is still proceeding, and only a preliminary case report was introduced about the use of dexamethasone. So it is not precise, that we cannot depend the use of dexamethasone. And also in the clinical trial, which is proceeding right now, they recommend the use of dexamethasone in ventilated patients. So and patients with mechanical ventilation and intubated patients. And these patients, in case of COVID-19 infection, have to have cytokine storm. So these patients, these specific type of patients, those patients which are in septic shock, in sepsis, in severe sepsis, and in case of bronchoconstriction, in case of severe cytokine storm, the timing of use glucocorticoid here is very important. And these patients which are, what I'm talking about, the shock, those patients which are hemodynamically unstable, those patients which are ventilated, and no any benefit or about use of glucocorticoids for stable patients. And for also critical ill patients, there are hemodynamically acceptable patients, not to say stable. We said that hemodynamically acceptable patients, but not all of the patients can use glucocorticoids. So we can use corticosteroids, but for a limited number of patients and in certain time schedule for these patients. This is my opinion. I don't know.
Thank you, Dr. Ali. Thank you, Dr. Al Hassan, for your question. نسأل مرة أخرى الحضور الكرام اللي عنده سؤال أو مداخلة عربي إنجليزي مو مشكلة، المهم نسمع أصواتكم وتتداخلون ويانا حتى نتأكد أنه المعلومات وصلت لكم إن شاء الله والفكرة وصلت. إحنا بالحقيقة راح يكون عندنا في السمري at the end of the symposium. I will give about 1 minute for each one of our speaker to give his summary for the attendees. But
you have questions, دكتور قتيبة. اكو أسئلة عندك بالشات أيضا تصير إذا تباوح.
نعم دكتور. حضراتكم دكتور please our speakers if you can read the or if you see the questions in the Q&A session you can answer directly please. You can answer, you can read it and answer.
Yes.
Okay دكتور قتيبة. دكتور قتيبة تسمعني؟
نعم أسمعك دكتور.
A question in the chat bar. There's something somebody asking about if there is any benefit of using xylocaine nebulizer in the treatment of COVID-19 and the use of hydroxychloroquine as a therapeutic or preventive drug. The answer of this question actually in the among the medical community, in the medical practice, we always asking for the like solid clinical evidence for the use of anything, because we are sitting now in an official webinar, so we only rely on the like solid evidences that published in like known journals or something like that. So the use of xylocaine has been went viral recent days, you know, because there was a doctor in Iraq always announcing and inviting people to use xylocaine in the treatment of COVID-19. I'm not with or against the use of xylocaine in COVID-19 treatment, because I read many articles talking about this like theoretical concept for using xylocaine in the treatment of COVID-19. However, again and again, we are waiting for a well-designed clinical trial that cut this debate and put us the questions about that. Regarding chloroquine or hydroxychloroquine, you know, since the study of Marsilia study that published or done in France about the use of hydroxychloroquine plus azithromycin, and since that time many medical centers start to use hydroxychloroquine and azithromycin either alone or in combination for treatment of COVID-19. However, in the recent days, the direction of the treatment was directed something else, because the risk may outweigh the benefit, because they, you know, the either hydroxychloroquine alone or even with its combination with azithromycin both prolong the QT and may lead to cardiac arrhythmia. So till now there is no like recommendation for using hydroxychloroquine as a preventive. Maybe only in India and some countries they use COVID, they approved hydroxychloroquine for the prophylaxis of COVID-19, but in the like United States, Europe, or even in Iraq, there is no official recommendation for the use of hydroxychloroquine as a preventive therapy. Yes.
Thank you, Dr. Mohammed. Thank you for good explanation of about the use of hydroxychloroquine, because it is controversial, and we read a lot of recent papers about the trials about the use of hydroxychloroquine. Some say that it is not of no benefit. There is no benefit, and some yes, it is controversial. I just want to give some points about COVID-19 in general. All facts, it is not clear until now, and all needed updated informations, and all clinical trials are proceeding now, and we just waiting for the result. And it needed, I think it needed about months to be clear about all these points. Now a Q&A session we have. If you answer, Dr. Okay, Dr. Shukran. In the chat. So our attendees, please, I'll give you the last 2 minutes if you have any questions in order to finish and to end our meeting. If you have any questions. Okay.
Okay. I'd like to add to Professor Al-Rekabi about WHO news on July 4th, yesterday, really. WHO discontinues hydroxychloroquine and lopinavir-ritonavir treatment arms for COVID-19 because the trial results show that hydroxychloroquine and lopinavir-ritonavir produce little or no reduction in mortality of hospitalized patients with COVID-19. So there is no recommendation for routine use of hydroxychloroquine in COVID-19 patients as a treatment.
Thank you, Dr. Bita, for this ad. Thank you.
So, question to Dr. Mohammed, I think in chat. دكتور ممكن حضرتك تشوفه بالchat المولد. نعم دكتور.
Do you think it's possible to use alternative remedy in cooperation with the protocol of treatment? If possible, what is the best of one? Again, alternative therapy, if you mean by alternative therapy as like herbal remedies, or maybe you're asking about the use of vitamins as a supportive therapy for patients with COVID-19. Vitamins, if you mean vitamins, so vitamins is included in our official MOH, Iraqi Ministry of Health. They recommend the use of zinc, vitamin C, and selenium, and vitamin D in the treatment of COVID-19. Regarding the alternative remedies, something else like we hear about many things that have been tried for the use of for the treatment of COVID-19. They are not like approved. But if you specify which one you mean, I can answer you about its efficacy and safety now.
Thank you, Dr. Mohammed. Now, yes, Zainab said in chat, like herbs. That's meaning herbal. Okay.
Yeah, herbs, Dr. Zainab al-Juburi. Herbs again, they like meet the same principles of whether they are effective and safe for treatment of such condition, because some of patients with COVID-19, about maybe 10%, they are maybe severely ill patients, and we can't try things that they are not approved or may bring some adverse effect for the patient. So we have to be aware, specifically in patients with severe cases of COVID-19. But regarding the patient with mild conditions, so I think it is maybe self-limited condition. It's nothing but viral infection. It could be similar to influenza virus. So it's self-limited, and we don't know whether the improvement is related to the use of herb or maybe it's spontaneously resolved. Yeah.
Thank you, Dr. Mohammed. Now our speakers, please, I'll give you 1 minute for each of you to give a summary of his recommendations or a summary of his presentation, starting with Dr. Bita Shahrami.
Thank you. At first, I'd like to thank you, dear Dr. Qutaiba, for your valuable efforts, and also Professor Al-Rikabi and my dear friend, Dr. Al-Ahmad. Really, it was a pleasure being here today. Nothing else. I just say that coagulation risk is very important in COVID-19 patients, and as you know, data is limited, and the further studies are required. Just this.
Thank you, Dr. Bita. Dr. Mohammed?
Okay, thank you, Dr. Qutaiba. And again, I re-thank the University of Basra College of Pharmacy for this great webinar and for your nice administration, actually, in such event. So thank you for this administration. And as in summary, I think I will talk with the medical community. I mean the experts, with the clinicians dealing with such condition. Please always for the clinical evidence that support go or rush behind the only the person tried something like and maybe successful on your patient, or you read about a case study and you extend the information to be like extended to be used for the public, because you know, public hear from a specialist and they will once you talk about something which is very effective in COVID-19, people may rush on the community pharmacy to try to take this medication from the community pharmacies, and this may bring a lot of side effect or adverse effect. This is for the community and for the public, and because you know, I don't know whether our participant or that hear you from the public or all of them are experts. So I will take a talk in 30 minutes for the public in Arabic. احنا نقول للناس اللي ناسنا واهالينا اللي يسمعونا سواء الان او بالتسجيل مالت المحاضره، انه هذا الموضوع يعني موضوع الكورونا لا نندفع كثيرا مع اي شيء نسمعه من الناس. يجب ان نتروى وننتظر انه ونستشير من المختصين هل ان هذا الكلام فعلا علمي وهل يضر الحاله مالت المريض او لا، لان الكلام صراحه في الانترنت الان كثير جدا فيه الغث وفيه السمين، ونحتاج الى راي المختصين لتمييز ذلك. وشكرا جزيلا.
شكرا جزيلا لحضرتك دكتور محمد. يعني النقطه اللي ذكرتها مهمه جدا جدا. الاخوه جميعا، الحضور جميعا، الرجاء انه توخي الحيطه والحذر في اخذ المعلومات، خصوصا بالسوشيال ميديا، لانه مكان خصب جدا للدجل. حاليا صاير مكان خصب جدا للدجل. اي احد عنده شيء يريد يروجه الان من خلال السوشيال ميديا ويقول هذا علاج للكورونا وهذا كذا، والتفاصيل اللي حضراتكم مطلعين عليها. Thank you very much دكتور محمد. دكتور علي.
Thank you, Dr. Qutaiba. At first, I would like to thank the speakers, my dear colleague, Dr. Bita Shahrami, and my dear friend, Professor Al-Rikabi, for their valuable time and for their valuable presentation, really. It is a very worthy symposium now, and I would like to be repeated again in the future. I ask Allah to save the whole from this pandemic, you know. And my recommendation for the public and for the whole is to be, don't be worried, is to be stable psychologically, because you know, one of the tools to win the virus is the psychological stability. And unfortunately, the social media uses and focus on the many fake news and many exaggeration in the news. This leads to decreased immunity and increased psychological activity, and unfortunately lead to increased mortality. The immune system is very important. In addition to that, the nutrition, it is very important. And one of the questions asked is how to manage mild cases in home or at home. The hospital's load cannot occupy and cannot receive all the cases. So it is very important for the patients with mild conditions to be quarantined in their houses. Only what is the treatment, and what is the treatment is the nutrition. It's the good nutrition, taking vitamins, taking zinc capsules or tablets, taking vitamins like vitamin C and vitamin D, also painkillers or antibiotics sometimes of value like paracetamol. And there is no need to worry, especially those without chronic illnesses. Those with intact immune systems can overcome the virus simply, and it is a short period, 5 to 7 days, they will become better and become very good. So thank you very much again, and see you in the next activities. Thank you, goodbye, and thank you for all.
Thank you دكتور علي، شكرا جزيلا لحضرتك، والحقيقة ملاحظاتك مهمة جدا. اخواننا الاعزاء، انا اود ان اتحدث خلال دقيقه باللغه العربيه من اجل انه نوصل لحضراتكم مجموعه من النقاط المهمه. ارجو الجميع، الى كل من يسمعنا سواء بالبث المباشر على الفيسبوك او اللي معانا الان في الزوم، اخواني ارجوكم، الذعر والخوف لا يؤدي الى نتيجه ابدا. اذا تقعد تفكر بالوباء من الصبح لليل ما راح توصل النتيجه، راح تبقى خائف، مناعتك تهبط، تزيد خطر التعرض للاصابه. شنو المطلوب بالوقت الحالي؟ شوي طمأنينة وشوي صبر، ويحتاج فقط نحتاط، ناخذ الاحتياطات المطلوبة، نقلل طلعاتنا خارج البيت. أرجوكم دائما احتاطوا، دائما غسل مستمر ومنتظم لليدين بالماء والصابون حتى وانت بالبيت. من تطلع خصوصا ترجع للبيت اغسل ايديك بالماء والصابون. الكمامة دائما البسها إذا تخرج إلى مكان، تدخل إلى مكان عذرا مغلق. إذا أماكن مفتوحة لا داعي للبس الكمامات في الأماكن المفتوحة، فقط في الأماكن المغلقة البسوا الكمامات، والله يحفظ الجميع من هذا الوباء. فأرجوكم إخواني، يعني هذه الكل الآن ممكن تلاحظ السوشيال ميديا الآن واحدة من مشاكلنا، إنه السوشيال ميديا يبدون ينشرون بها الصور ويومية فلان توفى، فلان مات، فلان مصاب وكذا، ويطلعوا لك يعني مجرد إنه أنت تشعر فقط بالإحباط والكآبة من وراء السوشيال ميديا، إحباط وكآبة مستمرة. هاي تأثر على مناعة جسمك، تأثر على نفسيتك، وهذا عامل مهم جدا في مقاومتك للإصابة أو مقاومتك لهذا الفيروس. فإن شاء الله يحفظ الجميع، الله يحفظكم ويحفظ أهلكم إن شاء الله، ونتمنى لكم الصحة والعافية. Finally, that's all for our meeting today. I'd like to thank our speakers from Islamic Republic of Iran, Dr. Bita Shahrami, thank you for joining us, and thank you Professor Mohammed Al-Rikabi from Najaf, from the College of Al-Kafil, thank you for joining us, and Dr. Ali, thank you Dr. Ali from College of Pharmacy, University of Basra, and thank you for all attendees, thank you for your time. Thank you for joining our webinar, and I hope to see you in the next time. Thank you for joining us. Goodbye. See you. Bye.
مع السلامة.
شكرا جزيلا لحضراتكم، في أمان الله، والله